Okay. High frequency brain signal. I will focus on methodology and the applications. This is what I'm going to talk about. First of all, I talk say a few words about high frequency brain signal, and then focus on several hardware, software, clinical application, and a few discussion. As we know, the brain generates electrical and magnetic signal in a set of frequency range. For example, the conventional delta, theta, alpha, beta. What I'm talking about this afternoon is some high frequency, typically we call it gamma or high frequency oscillation or ripple and fast ripple. And there are some variations among reports. Some researchers say about 30 hertz is high frequency. Some say 40. The majority of the research, we think high frequency is about 8 hertz. There is no standard name and term of frequency band, as you can see, for high frequency study. For example, conventional spike, we typically focus on the frequency range in 14 to 70 hertz. And in the function area, in particular the high brain function, we typically low gamma or high gamma. That's from 30 to 70 hertz. The high gamma typically from 70 to 150 hertz. In the clinical side, in particular in epilepsy, we typically focus on high frequency in 80 to 600 hertz. And the high frequency oscillation, they typically divide into several types. First of all, they call it ripple. Ripple is from 80 to 250. And the fast ripple typically from 250 to 600 hertz. When we talk about high frequency oscillation, typically the coverage from 30 to 600 hertz. And in recent years, there are some reports that focus on the very high frequency oscillation. And those high frequency oscillation typically higher than 600 hertz. Majority of the report focus on 1,000 to 2,500 hertz. As you can see in the this field, there is no standard names. So when you read the paper, some people say it's a gamma, some say it's a ripple, and recently some even say high frequency spike. In this presentation, when I talk about the high frequency, I included the high frequency oscillations. That is the most commonly used word in this field. If we want to classify the high frequency, there are several types. First of all, high frequency can be evoked high frequency, but those typically is a functional activity. And those could be low, we call it the GABA, low GABA, high GABA stuff. Another type of the high frequency we call it spontaneous high frequency oscillation or intrinsic high frequency oscillations. And those, as I mentioned, could be ripple, fast ripple, and sometimes they may just call it high frequency activity. And the pathological high frequency typically focus on the EEG field. Well, in the EEG field, particularly in the epilepsy areas, those the majority of the researchers we call it ripple and fast ripples. Recently, there are called high frequency spikes. That's a new area. It's still just a very few publications there. The frequency range is pretty similar. We call it spike length or fast spike length. That is corresponding to the high frequency oscillation called ripple and fast ripple. The cerebral mechanism of high frequency actually is not clear. Most of research think is simply is just the out of phase. Basically, it's just we know the MEG and EEG, we detected the brain signal from synchronous activation, the high frequency just because out of phase. Of course, there are some research thinking that the high frequency is from the axon gap junction. That's definitely is a new type of mechanism. It's not from a conventional synapse. I will expand a little bit. But one important thing we have to point out is that both MEG, EEG are intercranial recording. We are recording a signal from at least 10,000 of neurons, 50,000. There is no one answers, but just not just an estimation. It's a synchronized activation. It's not from a single neuron. This is just explain what it called the out of phase. As you can see, the left side is the conventional, we call it synapse. With the conventional MEG or EEG, we typically encode the signal from post-synaptic potentials. That means, as you can understand from the synapse, there's a neurotransmitter was released, the active the post-synapse memory. Remember, they generally the post activate potentials, and in the normal condition, they are synchronized. They form, like for example, alpha activation from 8 to 12 hertz is very synchronized. In some situations, they just out of phase is the right side of this figure. As you can see, when you measure it, you think there is some high frequency. Basically, that's just the out of phase. It looks like there are multiple high frequency there. Because the cerebral mechanism is not still not clear, there's still some still some research are looking into it. But there are several things I want like to make clear. First of all, there's pretty sure there's some different generator between low frequency and high frequency. Because low frequency we typically think is the post-synaptic potentials. High frequency we either don't know or there's some hypothesis, like I mentioned, is a gap junction, out of phase, whatever. But one thing is for sure, probably is different from the conventional low frequency signals. And the second important point is brain high frequency oscillation is not equal to the neural high frequency. Because one of the most asked question is, when we put the electrode directly on the neuron, we get a signal is really beyond 100 hertz. So how come you get the high frequency MEG and EEG? The MEG, EEG, as I mentioned in the previous slides, is from 50,000 of neurons. So it's a spatial temporal overlap. It's a mixture. So that's a difference from them. Another important point is that the typically low frequency is from the large area, high frequency is from small area. As you can see from the right side of the pictures, as you can see, a low frequency is from large area. So we talk about the high frequency signal. It's beyond 8 hertz, and the cerebral mechanism probably different from the conventional low frequency. Now I want to say a few words about how we detected them. The first important thing is hardware. As we know, in the neuroimaging technique for detect high frequency, there are possible several ways. One, of course, is we call it intraocular recording. That's the invasive. It's out of our discussion today because those technique, you need to open the skull, you need to put the electrodes directly on or in the brain. So it's invasive. Another technique is the EEG. EEG can detect high frequency. The third one is MEG. Other technology, for example, the widely used functional MRI, those technologies, they don't have the temporal resolution to detect the high frequency. So more specifically, as you can see from this picture, the MEG intraocular recording and the EEG, they have the temporal resolution to capture high frequency because they have the high temporal resolutions. MEG and the invasive recording, they also have the high spatial resolution. Other technology, as you can see from this picture, they don't have enough temporal resolution to capture those high frequency. So now we only have two technology that can detect the high frequency non-invasively. One is MEG, one is EEG. MEG and EEG, they have the many differences. This picture I want to show you at least two. First of all, MEG mainly detected the intracellular currents, and the EEG mainly detect the extracellular current. So they're different. And also MEG, they detect the measures magnetic field. The EEG, typically we measure the difference. That means the relative values. We typically use montage or reference, whatever we use. And the third important difference between MEG and EEG is MEG, they can pass through the skull skin without significant distortion. But EEG, typically they're distorted. So the important thing for this point is if we do source localization, at least theoretically, MEG should be much better than EEG. This is the exact data in the right side from our MEG center. As you can see, the MEG looks like a little bit noise, and the EEG looks cleaner. And actually, that's because the MEG they pick up everything is sensitive. That is important for high frequency recording. Of course, in the low frequencies, they are pretty similar to this. This is give you another picture to show what's the difference between the MEG and the EEG. As you can see, EEG typically measures the difference, and the MEG directly measures electric magnetic field. And another important thing is MEG signal the decay significantly with distance, but EEG, though they may decay a little bit, they get weaker, but it's still detectable. But this indicates that if we record in the deep source and the EEG, they have mixed like a deep and the surface. But MEG, if you measure signal, the surface signal much stronger, the deep signal is weaker. So that's a good point. So if we put all the difference together, there could be many. But today I will specifically clarify 3 points. First of all, MEG don't have a low pass filter. What does that mean? That means a high frequency neuromagnetic signal they can pass through the skin skull. And for EEG signal, they have the low pass filter effect. That means there's some research proved if you use the EEG, even though you still can detect the high frequency signal, but they filter something. Or the rough range about 30%, so already filtered out. And the spatial resolution, as you can see from here, MEG have a high spatial resolution, EEG has a low spatial resolution. And the MEG, you get a strong signal, it's more than likely from the surface. For EEG, you make it from both. And also another important difference is the MEG mainly detects the tangential, and the EEG typically you really get the radio signals like a spike. So in the clinical side, if we're looking for all the MEG data side, we will find like 70% of patients, they just show spike on both MEG and EEG. Another 30% of the patients, they may either show on MEG, but not EEG. Another 30% maybe on EEG, but not MEG. So that's the difference between MEG and EEG. So this study, because we think that the MEG has some advantages over EEG in the detection of high frequency signal. So this afternoon, I will specifically focus on magnetic signal, use MEG to detect different signal. This is a picture showing specific focus on the magnetic signal. As you can see from this picture, there's a ton of the magnetic signals from body or from the environment. But we will mainly focus on spontaneous, like that is pretty weak. It's much weaker than the environmental noise. And also the MEG from the brain is much weaker than the heart. This is the device in the our MEG center. Our MEG have the 275 MEG channels and 108 EEG channel. We can record in MEG and EEG simultaneously. The sampling rate is 12,000 hertz per channels. So that's a huge amount of data. So the next stop is here. Of course, I'm talking about the currently is we use the conventional MEG user squid. Recent years, of course, there are some new MEG technology. We call it the optical pumped magnetometer, as you can see from the tool. Why I mention this this new technology, because as I mentioned in previous slides, the magnetic signal decay with distance significantly. But the conventional squid always have some difference distances, as you can see from this picture, the MEG. And the OPM, they can put the sensor closer to the head. So that is good for the detection of high frequency signals. And also we can directly compare with the inverse recording to prove if there's real high frequency or fake or artifacts. Now we're talking about the method for detecting high frequency MEG. Definitely is a good tools. In particular, next generation MEG, such as optical pulse magnetometer. They can capture the high frequency. The sample rate is more than enough for our clinical research. The next section I want to talk about the software side, the algorithm method for detect high frequency. Over the past 10 years, there are tons of this method or algorithm have been developed for specific detect high frequency, in particularly high frequency oscillations. The conventional clinical way is just visual identification. They just look at it. I will show you example later. Just visually see if there are any high frequency there. If you understand the background is more than 4 oscillation, that's high frequency. And those visual identification typically based on the bandpass filter or mode bandpass filters. In addition, most of the conventional EEG just focus on sensor level. That means you recording the data, look at the waveform, take them. Of course, we have developed tons of the, as I mentioned, the new method. For example, accumulated spectrogram. That means you just like the conventional average, you got a non-recording, and then you summarize them and found the high frequency signal. Now I want to show one example and to say what I'm talking about. When we talk about high frequency, as you can see, one is at the sensor level, you direct recording data, you can see this is out of the background, you stand out from background, you can see this high frequency, this is conventional spikes. This is in stereo EEG, that means we directly put the electrodes directly inside of the brain. Because this is from same subjects and from same area, so we proved that this definitely is a high frequency brain signal with both MEG and immersive recording. That's how the high frequency looks like. As you can see, the high frequency is much weaker than the low frequency. Low frequency, like the conventional spike, are much stronger than the high frequency. In addition to take a signal at the sensor level, there are also some methods to take the signal at the source levels. Source level, there are some advantage there because they provide process spatial information and also they increase the signal to noise ratios. One most used method for detecting high frequency at the source level, we call it the virtual sensor. Virtual sensor basically is they use a computer to simulate a sensor within the brain. It's pretty similar to the massive recording or stereo EEG. We also can use the source imaging because source imaging basically localizes the signal, so also at the source level. This is the example of the virtual sensor. As you can see, even though conventionally we analyze data at the sensor level, we can use a computer virtual sensor like the red dots. Each virtual sensor generates one signal, as you can see. In this, the epilepsy patients, you can see some high frequency there, but with the normal subjects, even you put the same brain area, you see nothing. So the high frequency is always there. The epilepsy, they generally have high frequency. This is another example to explain how we analyze the high frequency and the low frequency. At the sensor level, as you can see, if we analyze the signal, we get some noise, background noise, as well as some high frequency. At the source level, if we use a spectrogram, as you can see clearly, there's some high frequency signal there, which is about 8 Hertz. So this is the example. What we have been done is just try to analyze the high frequency, make it simple. I will explain a little bit more. Another separated, you may ask how you separate the high frequency from brain from other artifacts. For example, you can be muscle artifacts. So how do you know what you have been working on is true brain signal, it's not artifacts? One important strategy is we use digital filter. Another, because high frequency, you couldn't be the filter rim. If with this digital signal, we don't filter them, as you can see, we can see it. That means the recording the EEG itself, they do have the high frequency there. And with filter, we just highlighted them. So with digital filter, so you can separate the two, use with filter or without a filter, because this can exclude the filter rim. So it's type of the data processing problems in the EEG field. Another we call it spatial filter. Spatial filter just with the weights like a beamformer. As you can see, high frequency brain signal, you can localize it into the brain artifacts. For example, like a muscle, you can say it's out of the brain, it's around the muscle area. If you compare the conventional low frequency and high frequency in the normal and epilepsy patient, this is the epilepsy, this is the health subject. As you can see, even though we both we can see the alpha activation, but only the epilepsy patient, they have high frequency. Normal subjects don't. But this one, because we can do the invasive recording, so we can validate the findings there. So I just showed the high frequency at the sensor level. You can see the waveform. This is the, we call it the accumulated spectrogram. This is a specific method developed to detect the high frequency. This method has some advantages. So the most important one is the process frequency information. As you can see, the straight line, so they tell you this exactly the frequency. So that's the one technology to detect the high frequency. This is the exact procedure how we detect the high frequency with accumulated spectrograms. So to explain them, just like as you can see, you recording multiple long recording data and then accumulate them, and then we can get the high frequency. This is 3D overlap. As you can see, this is the empty room, those subjects, control, the epilepsy. If we give just one picture with summary with the accumulated spectrogram, we can simply identify the high frequency in epilepsy patient. I mentioned about how we detect the signal in epilepsy. Epilepsy, of course, they have a strong signal, as I talked in the first slides. Another important thing is a functional high frequency. Functional high frequency, because as I mentioned, we need the evoked. We need some task like a 112, and you average them. The similar mechanism is the low frequency. High frequency, if you get the evoked response, you just accumulate them. It's similar to the conventional average. We can get the high frequency components. That one important thing is that they must be highly synchronized. That means that there should be no trigger jittering. If you have the trigger jittering, you will have a problem to get the high frequency, because the slightly trigger jittering, as you can see, it's gone. So to solve this problem, there are larger accumulated spectrogram, average them, as you can see, like this picture. So as you can see, high frequency, high frequency, high frequency, you average them, they may gone. However, if you use it, as I mentioned, you use a spectrogram, you average them, they're still there. So put it in a simple word, to detect the high frequency signal, either in epilepsy or in functional area, you need some special techniques or method. Otherwise, you may not get it. This is the exact procedure how we get the high frequency. We could accumulate source imaging, it is source levels. So I don't have time to go through all of them. If you're interested in, I can send you the more reference about this. This is a picture to show exactly how we get it. So MEG, we have the 275 channel sensors. As you can, with the spatial filtering, we can filter them, localize the signal like this. As you can see from here, this is called a spatial filtering. They filter them. And we also have compared different type of method to localize the high frequency. Sounds that definitely you need some special technique like accumulated source imaging to take them. The conventional dipole or other method like thumb, you might have some problems at high frequency. This explains how the source are accumulated. For example, with this segment of data, you get one source, and the second one, you get another one. With more than like 100, and you can get the accumulated sources. In our clinical research, we typically use the video card and to make the computation much faster. So you look at the source. Of course, as the development of the method, there are many research that are trying to use the artificial intelligence method to look at the high frequency. Let's make the process faster, more intelligent. And also some research trying to use the pattern recognition, wavelets, and the tons of methods there. And this afternoon, I will specifically focus on just one method. We call it the stacked space autoencoding. we developed this method. This method sounds work very well. If you get an image signal and it goes through the pipeline, they can automatically detect them. And this is more detailed method. Like you get all the from waveform, spectrogram to source, and then you can even integrate clinical data and go through all those procedures. They can automatically detect them and link to the clinical data. And also we can use some other more advanced method. For example, in the previous study, we mentioned that we can get a high frequency. Once you get high frequency, you can compute the network, see how they can communicate with each other, the brain, that's different brain areas, how they interact in the high frequency ranges. With high frequency, you can even volumetrically source estimation, as you can see from here. This is some of the sensory, you can estimate there. This picture just as I showed in the first slides, high frequency, we can divide it like a ripple, fast ripple, very high frequency. Some areas they call it the gamma, high gamma. There are tons of the high frequency. In fact, in the methodological issue area, you can compute it from low to very high, and then you can use the Braxton encoding to get all the source localization. As you can see from the down here, you can even color code in different frequency range and then localize them and then to search for the epileptogenic zone. That means, in other words, there are some methods we can analyze both high frequency as well as low frequency in the multi-frequency bands. So this is the goal. The goal is just to try to use all the high frequency to solve some clinical problems. We talked about their method, there are tons of method and software developed for detect high frequency. And now I want to show a few examples how we use those high frequency and method to solve some real clinical problems. In the clinical side, high frequency has been used in many areas. Due to the limitation of time, I will specifically focus on 3 areas. The first is epilepsy. Another is functional localization. Another area is migraine. That means a headache, type of headache. So this is the example from the epilepsy. As you can see, on the sensor level, this is the physical sensor level, and the source level, you can take the high frequency signal, you can localize them. This is just another from the real patients. This is from intracranial recording, as you can see, it's high frequency. This is from the MEG source imaging, as I showed in the method section. We can use a virtual sensor. We can compare, directly compare the signal from the electrodes and also from the virtual sensor. All of them from the can get some high frequency. As you can see, this is high frequency. The outstanding from background, that means in the highest amplitude. This is another clinical example with the stereo EEG. As you can see with X-ray, you can see exactly how we put an electron conventional method to detect the high frequency. This is image virtual sensor. This is our image sensor. This is virtual sensor we computed. Basically, the image virtual sensor showed the similar result as this stereo EEG. That means clinically, if successful, in the future, we can use a non-invasive method and to minimize at least the conventional invasive recordings. That's definitely potentially solve the one problems. Another thing is we really don't know in the clinic, we really don't know how the seizure started. With the MEG high frequency, as you can see, we can study in the one particular type of the seizure, we call the absence epilepsy. You can analyze the high frequency like before and during and after the seizures. So you can see exactly how the seizure started to understand, like for example, as I mentioned, absence epilepsy. Even though we know this seizure for hundreds of years, we really don't know because the thalamus or because the cerebral cortex, we have no idea. But with the high frequency and MEG, we provide evidence that the absence epilepsy is pretty similar to the conventional other type of the seizure is from cerebral cortex. I will show the more. As you can see from here, virtual sensor and the exact sensor, and they have the similar spectrogram. And this is a waveform. We compare the waveform and a spectrogram. This is the computer virtual sensor. This is truly recording from the brain. And this is a different type of the high frequency seizure onset. That means why this is important, because this shows high frequency propagations. So as you can see, the high frequency, how they propagate from one electrode to another electrode. But with the conventional low frequency, as I showed before, they don't have the time resolution. So this is I put all the together, try to explain. So as you can see, this is a waveform, conventional waveform with visual identification, with source localization. This is the intracranial recordings. We can directly compare the two. The MEG high frequency, they just pinpoint to the invasive recording area exactly. So this is another example, show the MEG high frequency localization. Non-invasively, this is the invasive. Now this is another slide show put all those together. As you can see, we can use a conventional accumulated spectrogram, identify high frequency, we localize them, and then we compare with the invasive recordings. So we put them together. Another important question is, what's the difference between the ecto and inter-ecto? But one important thing clinically, because when we see a patient in the clinic, the patient typically don't have seizures. But however, our surgery is trying to cut the brain general seizures. So what exactly the difference between the inter-ecto, that means the patient don't have seizure between seizure. This is the ecto, that means during seizure. Actually, with the image and high frequency, as you can see, both ecto and inter-ecto, they have the one component exactly there. In other words, seizure, it doesn't matter if they have the clinical seizure. The brain is always firing. That means high frequency. Even though they have conventional spike, they may not spike. High frequency sounds are always firing there. So that's the important finding there. Of course, you can use those high frequency to see how the seizure started, because they have the network they propagated there. Again, we can clinically, we can put all the high frequency together to localize them, try to figure out exactly where we call the epileptogenic zone. That means they provide a map to the neurosurgeon to localize them. We can put it from low to high frequency together. And we can even analyze the multi-frequency network to how they propagated there. So this is another example, and insular epilepsy, so how they work. This is how we analyze the data with the high frequency in the epilepsy patient. But the most recent study try to use use quantitative. The quantitative method we call the kurtosis on a score list. And kurtosis is one of the methods you can quantitatively define the high frequency. Because I showed it before, all those methods just give you the picture, give you a waveform, as I showed. But this method is different from the previous one. They can give you quantitative data. This is exactly how we calculate those parameters. As you can see, you can separate the different group of sensors and computer kurtosis. And then this is for example, this is a sensor, and then how we quantitatively compute the kurtosis. In clinical side, epilepsy patient, you can say the high frequency. If you use kurtosis, you can have the quantitative high kurtosis index. That means that they have the high kurtosis. That means here, as you can see, both kurtosis and sclerosis in the two frequency band from 8 to 250 and 250 to 600 hertz. We can also use the kurtosis-based source imaging. Instead of you looking at the high frequency waveform, you can compute the kurtosis and then do source localization. As you can see, this is two pictures in the ripple, fast ripple. As you can see, you can localize them. Those area is pinpoint to the epileptogenic zone. That means the neurosurgeon should target at those areas for surgery. So with the image, take a high frequency. First of all, we have to talk about there's an elevated kurtosis. That's the quantitative data. We can not only visually identify, we can compute them. And where we can also compute the source imaging based on kurtosis. And with those kurtosis, this approach is novel because why? We don't have to visually identify them, because visually identifying them is time consuming and subjective. And also definitely is better than the invasive with MEG. Another clinical important application is we call the high frequency spikes. High frequency spike is very important because conventional ripple and fast ripple, as I mentioned, the GABA, high GABA, you can see in epilepsy patient, you can see in the epilepsy. But in the clinical application, the problem is how do you know this is physiological or it's pathological? So that's a problem for clinical applications. And in recent study, we are trying to move to another important area we call high frequency spike. As you can see, high frequency spike is different from ripple. As you say, ripple is pretty similar to the alpha activity, is oscillations. But a spike is high frequency spike is we call it spikelet. It's similar to conventional spike. It's just one peaks. So this is the one peak is more like a more specific according to our data. As you can see, if you do time frequency analysis, a ripple, conventional ripple is more oscillations. It's high frequency spikes is more isolated burst. So that's the difference between the ripple and the fast ripple. So this is the counter map. As you can see, that's the strength of the MEG. They can pinpoint to some area, high frequency spike. This is normal subjects. Normal subjects, you don't have high frequency spike. And this is a very important pictures. As you can see with the MEG, you see the high frequency spike. Again, that's the clinical research strength. We can get the invasive recordings and use the invasive recording to verify the high frequency. So that means the high frequency in the MEG, high frequency spike in MEG is corresponding to the high frequency spikes in EEG, intraocular recordings. The high frequency spike, the important thing is more specific. So the second is a high frequency spike, they still include two. One is called a spikelet, another is a fast spikelet. We think this is the new biomarker for localized epileptogenic zone for epilepsy surgery. That's important. Since the MEG is non-invasive, we think this can help us to improve the clinical trial in the clinical study. Of course, all those data we can integrate into the neurosurgical system and help neurosurgeon to do operations. So this is summary of the high frequency oscillation, high frequency oscillation, and high frequency spike, and in epilepsy. As you can see, we can use high frequency to guide the neurosurgeon to do the resection, and here is the results. We can have the post surgical follow-up to get the outcomes. I talked about one of the important applications is epilepsy surgery, and I want to say a few words about the migraine. Conventionally, we think migraine is vascular disorder. So we use many type of drugs and try to cure the migraine, but at least 50% of patients may not be effectively cured. So there are always some problems with the headache in kids. And what we have been done is to use the MEG and the auditory motor paradigm. And this paradigm basically is a hair sound, push a button, and then we record the MEG. As you can see, this is different from epilepsy. This one is we use the evoked signal. As you can see from the MEG data, the evoked signal, the normal subjects control the gut response, finger movement. But with migraine, as you can see, they have the increased brain activation. That means that there are some the increased cortical excitability. This is another example. As you can see, this is normal. This is a migraine. This is a chronic migraine. That means so as you can see, chronic migraines, they have increased the cortical excitability. It's very clear. This is the spatial distribution. Where is the motor? What you can see from this picture is chronic migraine, they have the disorganized the cortical excitability, and in the normal subject, they're very focused. very focused brain activation during the finger movement. This is another example, show this, left and right. Another important finding in the high frequency study migraine is, as you can see, this is normal control. Once you move finger, you have the activation in the motor area. For the migraine, as you can see, they have the propagated activation. That's give a neural mechanism why migraine patient they don't want to move. They want to keep it in the dark and quiet area because the migraine, as you can see, they have the increased cortical excitability. Once they move, they have the propagated activation, which may cause a headache or migraine. So that's an important finding in the migraine study. This is, as you can see, in the ultra is the same. Not only have activation in the ultra area, they have some propagated activation. And the green color, the pinpoint in some area. So that's why, probably why migraine patients that want to stay in the quiet area instead of in the noise area. So we talk about two important applications. One is epilepsy, is a spontaneous activation, localized epileptic foci, rise migraine, which proved to be the cortical excitability problem. More specifically, is a hyper-excitable in the cortical. Now I want to say a few words about the functional mappings. That's another important area in a high-frequency study. There are many types of the functional area tasks. And this afternoon, I will specifically focus on just word comparison, just one type of language study. As you can see, we can show subject two types of words. One is sound auditory, that means the spoken words, another is written. Another is matched, another is not matched. If the words are not matched, they just push a button and then we get activation. As you can see, for the word recognition, we can exactly localize the language area. This is the word, abstract word. They can compare the words. They can localize the Broca vertical area. As you can see, this is language area, language area, language area, language area. And if you change the word, like a concrete words or the abstract word, they have a different activation area. So similar to the epilepsy study, we can analyze the brain signal from low to high frequency, use different color coding to localize how the brain process the word. Based on the brain activation, we can also analyze the connection. This example, for example, from 7 to 16 years old, and we can analyze the analyze the connection of the words. So high frequency listening clinically have the three important areas. One is epilepsy, or one is migraine, one is functional mapping. Functional mapping mainly used in the pre-surgical functional mapping in our hospital. And of course, you can use the same approach or method to localize the other function. For example, you can look at the visual, auditory, somatosensory, motor, and also even memory or some high frequency stuff. So that's a clinical. I want to say a few words the development of the high frequency. All the work I showed before is mainly focused on the high frequency with the convolutional squid. I personally believe the future probably use the OPM. Why OPM is important, as you can see from this picture, because I said in the first slides, brain generate different kind of signal, and the magnetic signal decays significantly with the distance. The new OPM, they can put it closely to the head. So I believe the future should be the optical pulmonary magnetometer, the new type of the MEG, which can actually localize the high frequency. That's probably breakthrough. Of course, we need some new algorithms to accurately separate those low frequency, high frequency is better in the multi-frequency range. So that's the future. In the clinical side, and I believe the conventional spike is just one portion of the epileptic abnormalities. High frequency, in particular high frequency oscillation, high frequency spike, that's probably the future. To solve the clinical problem, we probably need to use both high frequency and low frequency. According to our PATCH data, we can improve the conventional success rate for surgery from 70, from conventional 50 like to 90 for sure. So that means the high frequency definitely can solve real clinical problems in the future. So they go from the high frequency study is many summarize all the analyze method from hardware, software, and clinically we give one picture to solve the real problems. And all our study have been put in the website called the high frequency database. This is our website. We have some data there. If you are interested, you can contact us to either get the data or get the method. All the methods are freely available there. All my work have been supported by NIH, by Cincinnati Children's Hospital, as well as some grant from the Ohio State. I want to thank them for their support in my work over the past 20 years. Otherwise, I don't have anything to talk this afternoon. And thank you for your time and attention. I'm more than happy to answer any question you may have. Thank you.